It is with mixed feelings that we're going to start this panel today. This panel has been the brainchild for the last months of Dr. Shokey Yamada. This is his child. I invited him during the month of December or January, and like for many other speakers, I sent him a letter of invitation, and I was just waiting for somebody to come to the hook, and so I can put them in the basket. And for him was a totally different experience. All of a sudden, we had somebody who was in his mid-80s, late 80s, and he had the enthusiasm of a young adolescent. And he was looking for this very dearly. We were talking at the phone up to 2 times a day. We were emailing for up to 3 times a day, nonstop from January until last week. And then last week, on Saturday, he had to be admitted to the hospital, and now he's in serious condition. So all the people who know him know that he is not only is a great scientist, not only is a great neurosurgeon, but he's a phenomenal human being with a great heart, and it's very emotional right now for me. Dr. Yamada graduated from GK University in Tokyo, and he trained in general surgery and physiology in 1949. Then he had training in 3 different institutions for neurosurgery with the neurosurgical standards of the United States, in Toronto, Chicago, and Oregon. He ended in 1962. He went back to Japan for a year as an instructor, and then he came back at the University of Oregon. He had a very prestigious career, and he culminated with being professor chair for a long time in the Department of Neurosurgery at Loma Linda University. Right now he's emeritus professor, actually it should be say emeritus in Latin, but I'm not going to nitpick with you Americans, after retiring from Loma Linda. His research has revolved around many topics, but he is internationally renowned for his contribution to Tethered Cord. The basic understanding of Tethered Cord as it is today comes single-handedly from him, and was a convergence, as we're going to hear later, of many aspects. We practically attacked Tethered Cord from many different fronts. We attacked from the basic science, from the experimental part, from the pathophysiology part, and from the clinical and neurosurgical part. He had his PhD thesis, and he was studying muscle contraction and elongation mechanism related to ATP utilization. And like many people in this room, he had me at the low over there. But there was already the kernel to evolve to the next door neighbor, which was the problem with spinal cord tethering, which was at that point completely misunderstood. It is thanks to him that we're seeing the tethered cord problem with a different eyes these days. So he studied about the Redox and the CYTOCHROME AA3 studies. Dr. Webb is going to shortly tell you about them, but practically he came from the road of how the metabolism, how the function of the basic function of that structure was altered. And then he progressed, and it's like cherry picking, go one way or the other, and he came to the theory of tethered cord as a clinical proven disorder. It's part of the many, love emails that we had during the course of last month. I'm going to give you some excerpts. Dear doctors, this was a letter that he wrote to all the panelists in June 28, just a few days ago. The aim of this meeting is to advance understanding of tethered cord syndrome. In the 1940s, the concept of tethered cord was derived from the surgeon's visual perception that matched the meaning of tether. Despite criticisms toward this term being purely empirical, however, no attempt was made to analyze the underlying mechanism for 3 to 4 decades. Hoffman et al. In '76 and Yamada et al. In '81 brought light on the physiological concept of this disorder. As of today, skepticism still continues due to the fact that the diagnosis of tethered cord syndrome is made by neurosurgeons and neuroradiologists based on the anatomical findings for TCS diagnosis, mainly based on MRI findings. My concern, and again, these are the words of Dr. Yamada, is that relying on MRI leads to not only overdiagnosing TCS, mimicking disorder for TCS, but also overlooking TCS patients who are suffering from continuous back and leg pain associated with progressive neurological disability. So, in these last words is the summary of, but in a very serene and objective way, what has been the controversy surrounding tethered cord during the course of the last years in neurosurgery and among neurosurgeons. On one end, there are the people who are super conservative. On the other end, there are the people who are super progressive. The reality, the truth, is somewhere in the middle. And it is from tug of war that eventually, over time, we're going to reach the perfect balance. The spirit of the panel, as envisioned by Dr. Yamada, was just to have the spectrum of skeptic and believing ideas to be in the public open. The problem with tethered cord among patients is that obviously patients are going to look for an easy fix. So the tendency of the patient is going to be to buy automatically into a disease concept almost magically. On the other end, the person who's more grounded with basic science is going to be more prudent with this tendency. Again, is a balance between these two. It is, if you are just super prudent, you're going to leave many patients who could be helped out in the cold. If you're super aggressive, you're going to be at risk of over-operating on people, operating on some people who did not need the surgery. So all these aspects of this benign controversy is going to be analyzed today. So I'm going to introduce the panel right now. Dr. Yamada is not here, so he cannot give his keynote speech. So Dr. Monica Webby from Oregon is going to go through his slide presentation, who Dr. Yamada already provided me back in February because he was getting prepared. Dr. Rekate, that I barely know, is going to take the spot of Dr. Yamada as the chair of the panel. He is one of the most authoritative people in the room in the field of tethered cord and pediatric neurosurgery, and it was a fitting choice as an alternative. He's also a dear friend of Dr. Yamada. The three panelists are going to be, 3/4 panelists, are going to be Dr. Monica Webby and Dr. Petra Klinge for the quote-unquote believers, and I'm oversimplifying that. And then for the skeptics, and I don't want anybody to throw anything at him, is Dr. Cormac Meyer. I said 3/4 because inside Cormac Meyer, there are also the ideas that he had discussed with Dr. Iskander, who could not be here today he was here yesterday, but he couldn't be here today for family problems. So the way that the panel is going to evolve is that after this initial rambling from my part, Dr. Monica Webby is going to come here and is going to give the keynote speech that Dr. Yamada was supposed to give. Then after that, the panelists are going to alternate with each other, with Dr. Rekate at the end with a small piece about spinal shortening in tethered cord, which is a kind of a modern approach to difficult problems related to tethered cord surgery. And then we're going to have a session with a dynamic discussion. The way Dr. Yamada thought about it was he didn't want random questions. He didn't want the conversation to be outside of a narrative. So he decided to discuss with me over the weeks to have some clinical vignettes, with like hypothetical clinical scenario, and just pass it through the panel. You have seen during the last days, Chiari surgery is not done in one way only. the decision to do surgery has been pretty much uniform. Large syringomyelia cavities, they're an indication for surgery. Debilitating symptoms for Chiari, they're an indication for surgery. And most of the people are in agreement about that. About tethered cord, the major problem is not how to do the surgery. It's the opposite of the Chiari. How to do the surgery is pretty much the same for everybody. Is when to do the surgery that is the debate. So we're going to bounce these different variation on the theme of possible clinical presentation to the people of the panel. And the stress is that it's not that one is going to be right and the others are going to be wrong. There are simple different ways to approach the problem with the different glasses that we're having right now. Then after that, there are going to be a series of questions that are very dear to Dr. There are going to be 10. They were very dear to Dr. Yamada's heart. He went in England to preside one of the many tethered cord panels he did in his career. And a neurosurgeon from Birmingham asked him questions that in his mind were the most pointed questions about tethered cord that he ever received. Sometimes people can see a problem and come out with the exact words, very balanced, and they reflect an understanding, a higher level of understanding. And he enjoyed those questions, enjoyed answering those questions. So it depends how much time we're going to have left. If we're going to have enough time, we're going to pass it through the panel, and then we're going to go through the answers of Dr. Yamada. If we're not going to have time, we're going to have a combination of things. And I'm going to share with all the speakers by email the entire text of the answers of Dr. Yamada. The first time I read them, it was like looking at the big mountain. You do not really grasp it immediately. And then I read it the second and third time, and I got the kernel. And last night I was still getting layers out of his answers, which is bizarre because he was writing in Japanese American, and I'm thinking in American Italian. But something was passing through. So I'm going to switch to my IT hat, and Dr. Monica Webby from Oregon is going to come here, and is going to give the keynote speech for Dr. Yamada. I'm going to give a word of introduction for each one of the panelists. Dr. Monica Webby is the person in the United States who has done the most tethered cord surgeries. She has been part of the highest levels of the AANS. She is a former trainee of Dr. Batzdorf. She's a great surgeon, and she's a great presenter.
Well, I'm very happy to be here. I always really admired Dr. Yamada and was actually really disappointed that he wasn't going to get to be here. And but I guess I could say I'm a disciple of his, and so I will do my best to communicate his message. Some of his slides, I'm not quite sure what he was saying, but I think I know, so I will try to do my best here. So Dr. Yamada did a lot of work on tethered cord, and he believed that this was a syndrome, a stretch-induced functional disorder of the spinal cord caused by traction effects of an inelastic caudal structure, and that inelastic caudal structure is the filum terminale at the base of the spinal cord, and that's a developmental remnant left over from fetal development. I always describe it to my patients like your appendix. You know, your appendix was useful when you were a fetus and when everything was hooking up to be functional, but later all it does is cause trouble. Same kind of thing with the filum terminale. He believed it's a functional physiological state, and most importantly, that the symptoms are reversible if you catch them in time. Development of the concept Paulo talked about just a second ago. Historically, the concept of tethered cord began back in 1940, and we see a lot of this with our patients that we have with lipomyelomeningocele or myelomeningocele, patients with spinal cord abnormalities that as they grow, these cords will retether even if you untether them in a fetus or as in a baby, an infant. As they grow, a lot of times they stick back down and then traction again develops on the cord, and then you start to see this constellation of symptoms: back pain, leg pain, reflex changes, scoliosis, syringomyelia. You see all these changes begin, and those are bona fide tethered cords. Nobody's going to argue with you about that. But with these tethered cord syndrome, like we're discussing here, we see those same symptoms, but the MRIs will look normal. Other than, I always look for spina bifida occulta, but otherwise the MRIs look normal. So the term tethered cord was spread by word of mouth among neurosurgeons because when they went in to look at the cord, it looked tethered. It looked like it was being pulled on. And so he just defines the term tether as to restrict an object to its maximum range of motion, meaning that you limit how much movement the cord has. And then, of course, with any procedure, there are skeptics. And the skeptics are asking, well, what's the underlying mechanism for this? Does this disorder exist at all? And does surgical untethering help at all? Is it justified in any way? One of the first papers was written by Harold Hoffman. A lot of us older people in the audience knew and loved Dr. Hoffman. He described tethered cord syndrome as having variable signs and symptoms and contended that it was a thickened filum terminale attached to an elongated cord that was the culprit. Dr. Yamada put a paper together for Journal of Neurosurgery back in 1981 where he tried to clarify some of the ambiguities. And here, he actually put together a publication. I bought this years ago that goes through his testing and analysis of the condition. So here's his an example of a normal filum terminale. So this is the filum. It's not thickened. He gave the upper limits of normal as being 1.5 millimeters in diameter. And then here you see a slide of displaying the fibrous components of the filum terminale. So to try to prove this condition and what he thought was causing it, he did a lot of work with cats. I was looking at this before trying to figure out what animal it was, but there's quite a few. There's 7 lumbar rootlets, and then if this can't be human, and it was a cat that he's using here. And so he looked at different ways of trying to prove the concept of tethered cord, and started with anatomical, physiological, and then clinical. So anatomically, he has a cat spinal cord with a weight attached to put traction on the cord. And he was looking at the level of elasticity. So when you go back, he divided the cord into different sections. So this is division 1, 2, 3, 4, 5, and starting at the caudal end. And this is the filum. And if you look at the elasticity, you'll see the first section, the distal part of the cord really stretches a lot more than the rest of the cord. As you put the traction on each segment, there's less effect of the tethering. And of course, we all know that the bottom of the spinal cord controls bowel and bladder. And then as you go higher up, you start to get to the lower extremities. And then he also applying the weight directly to the cord and not applying it to the filum. And you can see again here, the traction is much more, causes much more of effect, much more stretching on the more distal end. And as you know, as all the neurosurgeons know, they're what we call dentate ligaments. If I go back to the picture here, dentate ligaments are all up and down the spinal cord. And the dentate means teeth, so it's like teeth holding the cord in place. They attach to the dura. So as you get further down to the conus, well, they call it a conus because it looks like a cone. Neuroanatomists were very basic in the way they would describe things. There's no dentate ligaments down there, so you don't have those attachments supporting the cord, and then you've just got that traction at the conus. And so that's why it's more susceptible to the traction. Now, I'm sure everybody remembers from basic science the oxidative metabolism in the mitochondrial cell membrane. So I was looking at this last night, trying to figure this out again. Sodium potassium pump. How many of you remember that? You know, looking at basically the metabolism of the cells. So he took this concept and was trying to determine how cell metabolism was affected. And of course, as we all know, if you use a spectrophotometer, you can look at this data. I'm kidding, of course. I don't know if we have any basic scientists out here who can give more detail, have at it. I would love to have the input. But basically, the way he was looking at cell metabolism was two different ways. First, he was looking at the energy production in the spinal cord neurons by sensory nerve root stimulation, looking at energy production, and then was looking at hypoxic stress to induce the reductive response in cytochrome A3. And if you look at his results, even if you don't really know what he was looking at, you can see that there's a difference, right? So if you look at evoked potentials, so here's the stimulus to the cord, and then this is the response. And this is with zero traction on the cat spinal cord. You put 3 grams of traction on, and you see that the response is much less. So here's your stimulus, and the response is much less. And then when you put 5 grams of traction on, the response is even less. And then with the cytochrome oxidase, so you have you put the cord in a hypoxic condition, put some in a hypoxic stress environment, and then you do a stimulation. In a normal cord, you're supposed to see a reduction in this A3, and then it recovers. But when you put traction on, you see less of a response. And then after you stop the traction, it'll recover again. And then with 5 grams, you see virtually no response. But when you stop the traction, again, you see recovery. So I think his point with all of that is that the traction does cause an effect, but when you stop the traction, you can still get recovery. And this was with a human, I'm not sure how he did this, but this was a human case of tethered cord with reductive response to hypoxic stress before and after untethering. And you can see here with the tether, the response is much less than after you untether the cord. So he wanted to try to take this evidence and put it to the clinical picture, to what we see in our patients. So how is stretch-induced spinal cord dysfunction correlated with the signs and symptoms of tethered cord? And so he designed the method to accentuate signs and symptoms by stretching of the lumbosacral cord. So his point from this slide is that when you go from flexion extension in the spine and the lumbosacral area, I always explain it to my kids, to my patients, like a rubber chicken. You know, if you've got a rubber chicken, there's a whole lot more flexibility and stretch in the spine than in the cord itself. So if you're looking at the lumbar spine, he saw that there was a 2.5 centimeter difference in the distance from top to bottom in flexion extension. So when you flex, there's much more length, much more pull, much more traction on the spinal cord. So he put together the symptomatic protocol, and these are the symptoms that he would see in these patients with tethered cord. So he saw that there was accentuation of back pain by what he called the Buddha pose, which is when you're sitting with your legs crossed in front of you, the crisscross applesauce or Indian style or whatever anybody used to call it, but he calls it the Buddha pose. And also you would see exacerbation by bending slightly over a sink. Again, that's flexion. And then by baby holding at the waist level. So I assume by this that he's talking about when you're holding a child, an infant at the waist, there's the additional traction on the cord just from the weight of the child. And so that increases the length the same as bending forward in an adult. With tethered cord, pain is worse when you're lying flat on your back. Spine flexion extension aggravates the pain. Back pain is worse with slouching than with sitting straight, and you'll always hear this in your patients with tethered cord. That it hurts when I bend forward to tie my shoes. It hurts, when I, put my head down to do whatever. So that is something that's pretty characteristic of the tethered cord, and that's explained by the fact that the cord has a longer distance to go in the flexed position. We'll see buttock pain on flexion extension because, again, that's the sensory pattern of the cord. The distal cord controls the perineal area. That's the sensation there. And pain extends into the groin, into the private or perineal area and the anal area. Patients will tend to stop walking due to leg weakness or numbness or urinary dribbling, and the hypothesis of this is that you have decreased oxygenation, decreased metabolism because of the traction on the cord. It makes it more difficult. And as you walk more, you start to get into trouble. They start to see the symptoms, the leg weakness, the numbness, the dribbling. And so as a result, the maximum walking distance will decrease. And there's decreased tolerance in riding in a car due to pain, particularly on bumpy roads. We see this a lot with the little kids in the car seats. A lot of kids scream when you put them in the car seat because they just hate being in the car seat. But these kids take it to a whole new level, of being uncomfortable when they're in a car seat because you're in your spine's in a flexed position, and then they're kind of trapped there. They can't move, when you have them in those little seats where they're locked in with the bar between their legs and they're strapped in and they can't move. So that can be real uncomfortable for them. And then the ability to stand still will come down to less than 60 seconds in a lot of people. And they'll tell you this. I hear this from a lot of my school kids. They'll stand up and walk around, and then they'll sit down, but then that's uncomfortable. Then they'll stand up, then they'll sit. It's real hard for them to focus at school because they can't stay still. Negative findings are lack of pain increased by coughing, which is something that we'll see with cord compression with herniated disc or other masses. And there's no radicular pain in the legs. The pain is localized in muscles, not in a radicular pattern like you see with a particular nerve root. Looking at the adolescents and adult symptomatology, motor dysfunction is most commonly seen in the extensor hallucis longus, lifting up your big toe. You also see motor dysfunction in the peroneus longus, which is plantar flexion of bending your foot down, pointing your toe, and everting the foot. These patients, when you're testing them in the clinic, will have difficulty with toe walking or heel standing. Pain and sensory dysfunction to pinprick in the lower extremities. Decreased sensation in the perianal area. Extensive sensory loss in patchy areas. And this is one thing that's pretty typical of tethered cord, is it's not a radicular pattern. You'll look at it and it just doesn't make any sense, where they're claiming that they're having this sensory loss. I would initially talk to these patients and they, I've got a loss here in this thigh and then this calf or whatever, and it wouldn't make any sense in a neurological pattern. But that's what you'll see with tethered cord. Urinary dysfunction, Dr. Yamada talks about post-void urinary residual as being one of the classic findings. And then musculoskeletal deformities, exaggerated lumbar lordosis, because you remember flexion puts length on the cord, and then the lordosis shortens the length that the filum has to go, that the cord has to go. And also we see exaggerated lordosis when you have increased tone in the legs, because that's something we'll see in our children with cerebral palsy. Scoliosis is also present, and I think all of us, if you talk to your orthopedic colleagues, they'll tell you that 90% of thoracic scoliosis is dextro to the right. It points to the right. But scoliosis related to the cord or to a syrinx or to tethering usually goes to the left. So if you see levoscoliosis of the thoracic spine, the first thing you have to do is look at the cord and be sure that there's nothing going on there. And also we'll see findings like the high arched feet and hammer toes. And these are also classic things that we see in kids with lipomyelomeningocele or myelomeningocele when they tether. Diminished sphincter tone. On digital insertion or on voluntary contraction. The anal wink reflex is diminished or lost. The anal wink for the patients here is basically the same thing as tapping somebody's knee and getting a knee jerk response. It's a monosynaptic response. It doesn't involve the brain at all. It's just hitting the cord and coming back. And post-void residual urine, he again talks about here. Flabby, hypotonic, atrophic muscles from decreased neurological input. Hypoactive, deep tendon reflexes. I've found that you can find hypo or hyper depending on where in the cauda the symptoms are manifesting, because if you can have either upper motor neuron, which is brisk reflex, or lower motor neuron if it's the rootlets that are the most involved. And then there's no pain aggravation on straight leg raise. And for the patients, when we're trying to rule out a herniated disc, you'll have the patient lay on their back, and when you lift up the leg, that puts traction on the nerve root, and that hurts. And if you bend their knee, then the pain is better. We don't see that with the tethered spinal cord. So here he has a nice comparison between herniated disc and tethered cord to help people make the diagnosis between the two. So with the herniated disc, it's a radiating dermatomal pattern. The pain will typically start in the back and shoot down the leg in a particular pattern. In tethered cord, it tends to be pain in the muscles, in the groin, and in the perianal area. With herniated disc, there's no pain on supine, lying supine on your back, and tethered cord is worse when you're lying flat on your back. Herniated disc is a myotomal dysfunction. There's particular muscles that are involved with a particular rootlet. In tethered cord, there's a non-myotomal dysfunction. A herniated disc is aggravated by coughing, but tethered cord is worse by slouching than by sitting straight. And then remember again, the pathway's shorter with flexion, or it's longer with flexion, shorter when you're straight. And then the 3 B's that he referred to, the Buddha position, the bending, and the holding the baby, those aggravate pain in a hernia in a tethered cord patient, but they don't aggravate pain in a herniated disc patient. You have a dermatomal deficit, which is a sensory pattern loss or sensory pattern pain going to a particular nerve root with a herniated disc, but with the tethered cord, it's more of a saddle distribution, what we call the saddle distribution, the perianal distribution, or an extensive or patchy sensory loss. There's no incontinence typically with a herniated disc. You can get it if you have cauda-equina syndrome with a low disc, but typically there's not incontinence, but with tethered cord there's incontinence. Paravertebral spasms in the herniated disc, but not in the tethered cord. And pain on straight leg raise in the herniated disc, but not in the tethered cord. MRI features, I couldn't see this on my computer, and I bet you guys can't see it on this either. But with the tethered cord, one of the findings that people will look for is the fact that the spinal cord is pulled to the back of the spinal fluid sac, and a lot of people consider that as a finding. Some people actually would have their patients lay prone, lay on their stomach, lay on their back, then lay on their stomach in the MRI and see if the cord falls forward, to see if the cord appears tethered. Nowadays, we'll use the cine MRI, the dynamic MRI, as our Australian colleague was discussing yesterday. Our dynamic MRI actually show you the amount of motion of the conus with a cardiac pulsation. So when you're watching that, I describe it as a guitar string. When the guitar string's loose, it'll flop all over the place. If it's tight, it doesn't move very much. And on a cine MRI, there's particular patterns that you'll see with the traction. I've been looking at those for 15 years, and I can kind of tell, how tight somebody is. I don't use that as a criteria in and of itself, but I use that as one more point in the constellation of symptoms when I'm trying to decide whether or not I think somebody has a tethered cord. He noted that an elongated cord or a thickened filum or a fatty filum was only present in half the patients, but he felt that always you'd see the cord pulled posterior. And he did intrathecal endoscopy, so he would take a scope and look in the spinal fluid sac and see where the filum was laying, whether or not it was pulled posterior or anterior. So if you've got a patient laying on their tummy and you're looking in with the endoscope, you should see the cord pulled towards the back. So symptomatology for an infant, because they're not really potty trained and it's hard for you to know if they're having accidents. So an infant would have constant dribbling of urine, paucity of foot movement, meaning they don't move their feet normally like a baby would. Foot deformity, sometimes a high arch deformity, sometimes a inversion of the feet, low tone in the feet, very flat feet. Skin stigmata such as a dimple. The dimple's usually right in the butt crack, right in the gluteal crease, the gluteal cleft. You'll see a dimple there. Sometimes you'll see a hairy patch on the back. Fatty swelling, which is usually fat, extra fat under the skin. A dermal sinus, which is a deep tract that goes in. Oftentimes you can't see the bottom of it. Or a hemangioma, which is a blood vessel collection on the skin. And young children, they start to stumble with their walking. They begin to dribble after toilet training. So one key flag, red flag for tethered cord is you have a child that potty trained and did okay for 6 months or a year and then starts unpotty training, starts having accidents. And that's something that we notice. Foot drop is another common finding. Painless sores on their feet. They'll scratch their feet and they won't complain of anything because their sensation's down. And then scoliosis. So here's a myelogram of the cord, and you can see the spinal cord comes down, tapers into a point at the bottom called the cauda or the horse's tail, because again, neuroanatomists were very basic. It looks like a horse's tail, so that's what they call it, the cauda equina. The cauda equina, the tip of the conus, is typically ends at the disc space of lumbar 1-2. That's your average finding. And here's an anatomical specimen. This is the bottom of the spinal cord, and these are the rootlets all coming off. You can see why they would call it a cauda equina or a horse's tail. And then here, you can see the filum terminale here. In real life, the filum terminale looks totally different from the rootlets. It's a different color, it's a different shape. The rootlets kind of look like linguini. They're kind of flat and they'll have striations on them. And the filum's kind of like spaghetti. It's more cylindrical. It looks totally different and it's a different color. I always explained to my patients that it's like electrical wiring. You can, it's color-coded. You cut the one string that looks different from the other 12 or 14 or wherever you are. And so then here is the phylum. You can see how it looks wider, and these are rootlets. And then here is a more thickened phylum that has fat in it. You can see it there. And then this is after he cut that phylum. And he remarks that after you cut the phylum, that the conus will ascend. And so it's under traction, you'll cut it, and then you'll see it ascend. And I've seen this actually on some of my post-op patients that if I have a patient who has a syrinx or something, I'll repeat the images afterwards. Oftentimes you'll see that it's ascended. And I more commonly see the shape of the conus going from more pointed to a little less pointed, not necessarily the whole thing, springing up like a curtain shade. It's not quite that way. But you do sometimes see it improving. So the conclusions that Dr. Yamada wanted us to take away is that the pathophysiology matches the signs and symptoms, and that stretching of the lumbosacral cord is manifest as the signs and symptoms that he described and that we see. On the MRI, you'll see a posteriorly displaced filum and conus. If you happen to put an endoscope in on your prone patient laying on their tummy, you'll see that the filum is attached to the posterior arachnoid. He's proven the loss of filum elasticity in the tethered cord syndrome. There's ascension of the lumbosacral cord on filum sectioning, and on histology, there's fibrous tissue that contributes to the filum rigidity. And when you're making the diagnosis and treatment, he recommends that you strictly follow the signs and symptoms protocol. You assure that 90% of the signs and symptoms are positive. On the MRI, you look for the posterior displacement of the filum and the conus. Intrathecal endoscopy, I don't know how many of you do this, but intrathecal endoscopy to confirm posteriorly displaced filum and conus before opening the dura and the arachnoid. Sectioning of the filum followed by immediate ascension of the conus, and then confirmed fibrous or fibroadipose replacement of the entire filum. And so that is what Dr. Yamada had to say, and I think I got the big picture. So anything you would add?
No.
Okay.